So let's have the next speaker. Now, we all do biometry, corneal, K1, K2, axial length. Does corneal topography allow you to get better results? Is that something that is really useful? And if it is useful, how do we make it useful? How do we go about it? We have Dr. Jeyanthan who will take us through that.
Thank you, sir. Okay, thank you, sir. So I'll be talking on the topographic aspect of refractive cataract surgery. So this is a famous quote from The Art of War. So according to the cataract surgeons, to get bang on every time with your results, you have two variables as the most important point of this. The most talked of enemy would be the topography, like keratometry values. So it helps us in pre-operative, post-operative, and future it is going to be the topography which is going to define all the questions that we have in our mind regarding the calculation errors. So to start with, we have certain technical pointers we need to understand. So we have an axial or a sagittal map, and we have a tangential map. So the basic difference is that the tangential map tends to exacerbate and magnify what you are normally seen on an axial or sagittal. So this is actually very, very, very helpful when you are talking about a post-refractive surgery. As you could see, the left part is an axial map. This is a post-refractive surgery. The tangential map actually gives the size of the optical zone and the position of the optical zone in respective to the pupil. So it gives you more data, more answers to certain questions when we have a doubt post-operatively. The diopter scale of the map is also very important because when you have a larger diopter, you may tend to miss out on softer aspects of the cornea, and if it is a very shorter steps, you'll have two noisy maps, so it will be very difficult to understand. So having somewhere between 1 to 1.5 diopter step would be the right choice. So set these two things, look at the tangential map and set the diopter map right before you interpret it in respect to the cataract surgery. So we'll start with the clinical pointers. Everyone knows if there's a scar, definitely it is going to affect. But what is the impact of this particular scar on your calculation will be told only by your topography. Similarly, a pterygium, whether to remove the pterygium or to do a pterygium after, alongside or separately, the effect of pterygium on the cornea should be studied with a topography map. Ocular surface, when choosing the IOL, the first consideration is going to be a tear film. An irregular, unstable tear film will affect the biometric measurement of IOL power calculation, and after the surgery also, a poor film can degrade the quality of vision. So remember, if the Mayas are not crisp and clean, the validity of all the other measurements are going to be diminished. So this holds true for the AIOC, and the Placido ring-based corneal topography will also be affected by the dry eye. So try to look at the Mayas when you are actually calculating whether it is an AIOC or a Placido-based rings. So even when you do an optical biometers like lens star will be affected by the tear film instability. As you could see here, the Mayas are irregular. And once you see a high standard deviation, it is always good to go and check the image quality before you validate these measurements. So the solution is going to be a topography, but the topography will give you a value. But remember, you need to treat the ocular surface before you do the surgery. Otherwise, post-operatively, the patient will be troubling you. The main thing is assessment of the corneal astigmatism. The topography may be used to assess the pattern of corneal astigmatism and the surface regularity. So it is useful for qualitative assessment of the cornea to know whether it is a regular, that is orthogonal or a symmetric bow tie pattern, or an irregular, that is an asymmetric or a skewed bow tie pattern. So this decides whether you are going to implant a toric or not. And next is a quantitative assessment. It depends on the surface regularity index, the surface asymmetry index, and the corneal higher order aberration that is being derived from the topography. Right. Once you have a corneal astigmatism handy, the treatment options are the astigmatic incisions, LRIs, OCCs, and the toric IOLs. When it comes to the astigmatic incisions, the cornea doesn't have axis. Remember, it's just a meridian, and you need to place the incision on steep meridian. And with the current understanding, putting it on a steep meridian, especially when you're operating a 2.2 mm or a 2.4 mm incision, temporally doesn't actually add much to the corneal astigmatism. So when you're planning a LRI or a killer corneal incision, the first thing is when you plan it, you need to plan where to make the incision. So you need to know the thickness of the cornea at the periphery where you are making an incision, because if you're planning a 600 micron LRI, you cannot do when the cornea has got a 400 microns. So knowing where to place and the depth of the incision depends on your topographic values. And after doing a CCI, in case if you want to know how good is the effect on that particular cornea, you need to do the topography postoperatively to the node. So you need to design your own nomogram when it comes to the LRIs and CCIs. Toric IOLs, it's difficult to correct asymmetric bow tie patterns, so you need to know whether the cornea is regular or irregular. And remember, the prevalence of irregular astigmatism is almost approximately 40%, and this could be picked up only by a topography. These are certain scientific evidences which says that if an asymmetric bow tie is being corrected with the toric IOL, the more the amount of asymmetry, the lesser is going to be your outcome. And there are studies which says that irregular astigmatism can be corrected with toric IOL if the central 4.5 mm has got a regular pattern. So all these are done using a topography. So only when you have a topography, you can validate your measurement postoperatively. So to conclude all this, to be more practical, if the corneal astigmatism value obtained with the corneal topographer and any of your biometer, if it is same, then probably you are good to go ahead with your toric IOL planning. The next aspect of topography is that it gives the EKR value, which is the Holiday's calculation. So this will give you a value at every zone of the pupil, 3, 4, 4.5 mm. It is good to go with the 4.5 mm pupil. And when you look at the distribution of EKR in the actual zones, you can see whether this patient is good for a toric IOL or not. When you have a high peak at one point, you will definitely have a good outcome. As you could see here, the mean of this cornea is 47. The peak is at 47.8. So naturally, this patient will have a 0.75 outset, even if you take a toric IOL. But seeing the corneal astigmatism, it is almost 4 diopters. Instead of leaving this patient with 4 diopters, it is good to go with 0.75, even a residual is also fine. But you need to explain to the patient beforehand. And this is one example where for post-refractive eye, the peak is very good. So this patient will definitely do good with your toric IOLs. Customizing IOLs, this is actually a role of aberrometry. I think the others will be talking, but still you can do with your topographer even if you don't have an aberrometry. Remember, your cornea will have a slight positive spherical aberration. Your natural lens will have a slight negative spherical aberration. So the total is going to be slightly positive, plus 0.1. Once the cataract develops, it's going to be high positive because the lens will become positive. That's the reason why most of the cataract patient has got all these photopsic symptoms. So when you're knocking off the lens with an IOL, depending on the IOL spherical aberration, your total eye aberration will actually, spherical aberration will change. But it could be plus, minus, or it could be a neutral one depending on the lens that you're going to choose. Okay, so this calculation is valid only when the natural cornea spherical aberration is a constant, but it is not going to be a constant. So this could be measured using a topographer. So when you have a topography, when you can measure the spherical aberration of the cornea, because anyway you're going to knock off the lens. So if you know that of a cornea, you can tailor make your aspheric lens selection depending on the corneal topography's value and a special software program that has been used. Post-refractive surgery eyes, definitely it is a nightmare. This patient walked in for a cataract surgery. This was the biometry values. Usually when it is
mathematically expressed. So there are various wavefront aberrometers present. Some of them do only aberrometry alone. Some of them also give you corneal topography as well. I will be restricting my talk to eye trace as I have the most experience with that alone. So let's start with one. Let's go with preoperative planning. So how can aberrometry help you in your preoperative planning for your patient who is going to undergo a cataract surgery? So as you see, as you know, when you're using premium IOLs, good centration of the IOL is a paramount factor to give you a successful refractive outcome. In diffractive multifocal IOLs, if a patient has a large angle alpha or angle kappa, you know that decentration can reduce the optical quality. So excluding such patients from your premium IOL practice could be a good way to go about it. So also, even if the angle kappa is also large, this can also give you sub-standard results. So the aberrometers, when we use them, we can also measure the amount of angle alpha and angle kappa. The eye trace does this very well. An angle alpha less than 0.3 mm is supposed to be ideal. 0.3 to 0.5, you have to be a little careful. More than 0.5 is a patient who has to be excluded from premium IOLs completely. So here is an example of a patient who has a normal angle alpha, angle kappa. So as you see here in both of these scans, both are within 0.3 mm of each other, which means that the patient is a good candidate for premium IOLs. Whereas this patient has a large angle alpha and a large angle kappa. So for this patient, a premium IOL might not be the best option as they will be looking through the diffractive rings per se. So let's go by a case-by-case basis. So this is a patient who is a 59-year-old male. best corrected vision in the one eye was 6.6 N8. So the slit lamp examination, he really did not have that much of cataract. He just had nuclear sclerosis, a little bit of posterior subcapsular cataract. But for this patient, as we see here, when you look at the eye trace images, what the eye trace does is it actually breaks down the optical systems. It tells you the aberrations in the cornea, it tells you the aberrations in the lens, and also gives you the total eye aberrations as well. So the first part is the aberrations in the cornea. It's given by a simulated E chart. It tells you how the patient is looking at the Snellen's letters E and tells you how distorted it is. But as you see here, if we go to the internal E chart, it is very distorted, which means the patient has an aberration in the optical lens system, which means that this patient is a patient who needs a cataract surgery sooner than later. So this can help you in a decision making on when to do your cataract surgery also. Case 2, this is an anesthetist who also had the same issue. The vision was quite good, 6.6, the 6.9 N6, but she had some posterior subcapsular cataract. As you can see here, the preoperative aberrometry in the first picture there, it shows that the internal lens aberrations is a little high. So it means that the patient is having a lot of optical image quality disturbance because of aberrations. And the second image, as you see here, after the cataract surgery, her aberrations have improved, and the optical quality of the E chart is now up to 10. So which means the image quality has drastically improved from before to after the surgery. It can also help you in ocular surface inflammation. So as you know, we all know, dry eye, it's a multifactorial disease characterized by inflammation of the ocular surface, which gives rise to an irregular tear film. So this can also affect the quality of vision. So this is a patient who underwent flax with a premium IOL placement in both eyes. She was having unaided vision of 6.6 and 6, but her TUBT scores were very low. She was put on a protocol for dry eye disorders with oral doxycycline, omega-3 fatty acids, and lubricating drops, and observed after 6 weeks. And she also underwent LipiFlow treatment. And as you can see here in the analysis, we see that her glands are very badly dropped out with a lot of MGD. And this is the change analysis after treatment of dry eye. So as you see in the first slide, the corneal aberrations are high. Lens aberrations are okay, it's still around 8.9, but the eye trace clearly tells us the issue with the optical system is with the cornea. So after we treat the dry eye in a disorder with lubricants and doxycycline and anti-inflammatories, the image quality has improved a lot, and the aberrations have all come down, and now the E chart shows us an optical quality of 10 out of 10. This is the same patient. As you can see here, this is a breakdown of all the aberrations in the eye. She had a lot of coma, trefoil in the internal aberrations parameters, which means the corneal aberrations are very high. But after treatment with the dry eye, they have all come down. So this just goes to show how the eye trace or other aberrometers can tell you where the pathology is, whether it is corneal, whether it is the lens, or whether it is internal. And you can come to a diagnosis and treat the patient appropriately. It also gives you this is called modulation transfer function. It describes how the objects are obtained in the form of an image in the lens. Basically, if a ray of light passes through the optical system, it sees the amount of spread that is happening in the optical system, and it characterizes as a factor of modulation transfer function. So this can also be termed as contrast sensitivity. So in the left is a patient with a cataract. As you can see here, they have lesser MTF. At 10 cycles per degree, it is less than 40%. But after surgery, it has improved to the normal one, which is above 40%. So this is the MTF before and after the patient when they had an EDOF IOL placed. So the left one, they have less contrast, and after the IOL is placed, the contrast has increased to the normal, more than 50%. So again, this is another patient who has had a monofocal lens placed, and as expected, the monofocal lens has the highest amount of MTF or the highest contrast sensitivity at about 60% at 10 cycles per degree. So you can also use this to track your outcomes with your different IOLs, so you can see which one has the best MTF, and you can keep that IOL choices in your armamentarium and choose the patients who need which IOL they want to. Another very useful one is called the potential visual complaints. So as you saw here, the previous parameters had the Snellen's letter E chart. So this is a simulation of the eye trace system and how the eye would see the projected E chart, and it would tell you what potential visual complaints the patient could have. So this is another patient, 65-year-old, who underwent bilateral multifocal IOL surgery, and now she had PCO. But her vision was not so bad per se. She had 6.6 parts N8, 6.9 N8 in the other eye. Some PCO was there, not very drastic, but there was some capsular wrinkling. But then you look at the MTF. So you see here that the MTF, it tells you both in the cornea and the lens, there's a lot of aberrations, which means that even though the PCO and the wrinkling was not so much, but because it's a multifocal IOL, these IOLs are very, very sensitive to even mild PCO or wrinkling. So this patient will really benefit from a YAG capsulotomy. So if we see here again, we look down, there's something called as potential visual complaints. So this tells you how the patient is seeing that E chart in the Snellen's chart. So he had a lot of blur, double vision, starburst, etc., which will degrade the quality of vision. So after the YAG, all of this went away, or at least it reduced quite a bit. So after the YAG is over, all the potential complaints are gone, and the E chart is a little more stable with better optical quality. Finally, it can also help you with toric IOL planning. So this is another patient who came with a 2.50 cylinder power, and he underwent cataract surgery, and we placed a toric IOL. Evaluated on the post-op day 5, he had a -1 cylinder left behind, but he had little bit of optical quality disturbance, even though he was able to read 6.6. We took him to the eye trace. The eye trace also has this thing known as an toric IOL evaluator. It tells you if the toric IOL is placed in the correct axis. As you see here, they had some amount of starburst and halos. And we look at the toric IOL calculator, and it tells us that we were off axis, and they required a rotation to the correct axis to give back the patient the good quality of vision, even though the residual is only about -1 cylinder. So after this was done, the patient's complaints went away, and they were on the way. So to conclude, aberrometry is a useful tool when evaluating a patient for refractive cataract surgery, helps you in your decision making in the preoperative period. It can also used to be planned, and you can track your outcomes with the IOLs. You know which IOL gives you what outcome. You can see the contrast sensitivity. And the wavefront aberrometry can not only help you in the pre-op planning, but also can help you in post-op troubleshooting and help solve patients who are having those odd issues. Thank you for your attention.
Yeah, that was really a very good exposition. It's quite important for us to understand what the patient is sometimes complaining of does not fall into what we are potentially observing. So it's common to see the case sheet that comes up to you where it says 69N8 or 66N6, but the patient is bitterly complaining of poor quality of vision. I can't see clearly. Everything is waxy. So when you do aberrometry studies, that throws out as to what exactly is going wrong. One potential problem, a dry eye. Second potential problem, minimal PCO. Third potential problem, that is the quality of that particular multifocal IOL or the EDOF IOL, where the MTF and contrast sensitivity is going to be low. So then when you start looking at all of these things and correct them, it is invaluable that you can find out the MTF of the lens inside the patient's eye, how it is behaving consistently, and that gives you an advantage of choosing the particular lens that is most useful in your practice. This is something that's absolutely invaluable. What the manufacturer says as an MTF on the optical bench can be subtly different as the MTF that this particular lens gives in the patient's eye. And if you have implanted 10 or 20 of these lenses and you have screened the MTF for every one of these patients, and the MTF is good, then you know this lens can be put into any kind of a patient that walks into your practice, and you can expect good results. If the MTF is consistently low in a particular lens model, then be ready that these patients, though they read N66, N6, if they are demanding patients, they are going to be unhappy. So there is a difference in cost in these lenses that give good MTF to poor MTF. So then you can start choosing these patients, non-demanding patients, older individuals, sedentary lifestyle. Then if they're going to be happy with the lower end multifocals, put that in. If you have an active patient who's driving and who's very particular about quality of vision, then you should push them towards the other end. Or if they're going to be too demanding, okay, give them the monofocal itself. So looking at the aberration study is just not the aberrations of the eye. You can use these aberrometers to study the MTF of the lens. That's extremely important. Not many instruments give you this facility. Eye trace is one. So using it extensively can make a difference to your practice and more number of satisfied patients. Any comments, Ramesh or?
Actually, I have a question for you. So can you tell me, does the MTF change depending on the pupil size? Does the lens MTF change depending on it's a small pupil, medium size? Does it change with background illumination?
I'll answer that. The eye trace takes the reading with the standard, say 3 mm or 4 mm pupil, whatever the patient has. But because the eye trace is also a topographer and an eye tracing, you can, on the machine, enlarge the pupil artificially. You can say go to 5 mm pupil, 6 mm pupil. So it will tell you at 5 mm, 6 mm what will be the... So you can actually study the MTF of a particular lens or a system at different pupil sizes, though you've recorded it on one pupil size. So that again, it's a tool that can be used to give you excellent results. So if there are no questions on aberrations, now we'll go systematically. We've done the biometry, we've done topography, then we've done the aberrometry, we've done everything. That we still have to do a good surgery to get good results. So how do we go about doing the so-called perfect phaco?